Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased today to be talking with Dan Spiller, who was Director of Health and Welfare for the Mead Corporation in Dayton, Ohio, some years ago. He's now retired. Welcome, Dan. Glad you are with us.
Thank you.
Joined by Jed Constance, who is a fiercely independent consultant focused on primary care. Jed, welcome to our soiree.
Oh, absolutely, Larry. This is great.
Also joined by Allie Abel, a fourth-year medical student from Albany Medical College. Allie, thanks for joining today.
Thank you, Larry.
So I'm going to turn things over to Jed here to lead the questioning. Jed?
Thank you, Larry. And thank you, Larry. And Dan, welcome. This should be a fun conversation. Given what you did and given what I know about Mead as it once existed, and as Larry pointed out, I'm fiercely laser focused on primary care from two perspectives: from the purchaser perspective, who is the self-funded employer, and from the primary care perspective, the community-based source of primary care that is by rights is attempting to do the right thing on behalf of their patient or your covered individual. And so you'll hear me use that phrase, covered individual, which is employer speak, but I'm really talking about the patient as well. So let me start by asking you, frankly, a fundamental question that, given that you were in charge of medical benefits for Mead Corporation in its various locations across the United States, what was it that led you to believe at that point in time, and certainly remind us when this was, but what led you to believe that a strong primary care strategy was in the best interest of Mead and its covered individuals?
Well, it was a lucky happenstance that I met a physician, Dr. Bob Reed, from Charlottesville, Virginia. He was the former chief of primary care at the medical school there, and was running an organization called the Mead Health Alliance. Called the Commonwealth Health Alliance in Charlottesville. And through a number of the discussions that we had, because he had the same focus on primary care, I could not figure out a way to give each individual family that were employees of the Mead Corporation, each individual family, some kind of guidance. Managed care tried to do that, and we had those programs, and it wasn't really working. It was more of a stop sign as opposed to, here's what you ought to be doing. So, and our organization was so scattered that we had a lot of people in very rural communities. So networks of any kind just didn't hardly exist except through Blue Cross, and that simply included everybody. So we were trying to give leadership, if that's the right word, to the people who knew the patient best, and we hoped that was his primary care doctor. We wanted somebody managing the show, and we couldn't hire people outside. It didn't make sense. It became clumsy. So between Bob and I, Dr. Reed, we said, why don't we simply focus this on the primary care physician? And if we can run everything through him, we don't have to have a contract with a family doctor. He'll just do what he was trained to do. And he will become the advisor for all medical care. He will determine what he can do, and he'll do it. and he can determine when it needs to be outsourced to a specialist.
So in a sense,
And we
you were
didn't-
looking at, primary care as a medical director for each community.
No, for each individual.
For each
Not
individual,
for a
even
community.
even
Yeah, we wanted
even
it
better.
specific to the family. So that's what it wasn't looking for a doctor to help with each community. We were looking for a very, very personal kind of a relationship, and that's what family doctors do. And by the way, we use the
Yes.
term family doc, which
Yes.
would include GPs, IMs, FPs, and anybody remotely associated with primary care.
Understood. And what year was this?
I got to meet in '88, so it was probably 91 or 92, because we kicked it off in '93, if I'm remembering correctly. The decisions were all made in '93, and the plan first became effective in January of 1994, and that got us
Perfect.
started down this path.
Excellent. And let's hear it for Dr. Reed, because that type of role and opportunity for primary care was not widely discussed. Many primary care communities were still reeling from the very bad position they were put in from managed care, from HMOs.
Right.
Gatekeepers, if you will. And so let's hear it for Dr. Reed and your ability to translate what he was sharing with you into a working model.
You missed a word in there. They were gatekeepers, but they were capitated gatekeepers. That was
understand.
That was the
Understood.
point.
Yes.
But by being capitated, they were, if it was going to make any money, they then could farm them out. They were discouraged from providing a long range or wide range of services because they were being compensated for that. Pass them on to the next guy. And it was
understood.
working against the practice of primary care. And that's what we didn't like about it.
No, absolutely understood. Many of us had that opportunity, unfortunately and fortunately, based upon what we learned, as to how that original design really undermined both the financial integrity of primary care and, frankly, the well-being of the covered individual. So let me ask you this: once you went live, January of 1994, what process did you use leading up to that to communicate the program that you had put together to covered individuals in order to draw their attention to it? Was it an opt-in program, or was it something that everyone was expected to enroll in? How did you communicate this?
First of all, we started with a program, a very small program, prior to this time, in about 600 employees. We ran a pilot project. But by the time we got around to 1994, we had already decided that if this program was as good as we thought it was, everybody should have it. And so we had a flexible benefits plan, 4 plans, primary difference being the deductible. But the Mead Health Alliance applied to every salaried employee in the company. And we covered all employees and all families. So it wasn't completely non-contributory, but the contribution was so light, we virtually covered all employees and all family members. And to answer your direct question, we rolled it out selling the primary care concept. In other words, it was relatively simple in description, but it turned out to be less simple in execution. The description was, you see your primary care, you see your family doc, to use the right words. You see your family doc first with any condition, and that's where you start. And he'll recommend somebody, probably, that you should go see. Now, once you've told him what your condition is, you do not have to follow his advice to get the higher benefit level. You could go to any specialist that you want. But if you change specialist, you had to go back to you were not allowed to go specialist to specialist to specialist. Every time you had to go to an ologist, you had to go back to your family physician and discuss that with him. And then he will refer you to somebody else, but it wasn't referring you to somebody else on a list. It was whatever his experience told him you should go. And that was the gist of the rollout.
Okay, so in a sense, you were educating your covered individuals on the role of the family doc and the importance, and the importance of a relationship with your family doc.
Right. And guess where the biggest pushback came from? It was women who were using their gynecologist as their primary physician. They did not want to have to give up that relationship and go find another doctor. And that became a real thorn, but we didn't relent. You wanted the higher level of benefits. You found and used and named in advance a family doctor. Now, the naming in advance wasn't so that you could see if he was in the contract, because there weren't any. You can pick any family doctor, but getting somebody to write it down and send it to you was a big deal.
Yeah. And
now,
important
in
deal.
The background was important. And now, in the background, Dr. Reed's group would call that family physician and say, look, we would like to establish a relationship with you. We've got a patient that's going to be coming to you, no strings attached, and this is what we want you to do. We want you to manage it the way your practice is normally managed, but to get the higher benefit, they've got to go to you, and we want you to understand that. And the doctors were absolutely thrilled. I mean, they were on board. So that's
especially with
there was that administrative piece in the background, so that when a claim came in, it was an easy cross-check to see, are you using the doctor you said you were going to use? You didn't have to keep going to that guy, but it made the administration a lot simpler and faster if you already gave us that name in advance, and that's why we did it. Okay.
Understood. Well, you actually anticipated my next question by describing what Dr. Reed and his organization did to support you, because often what's missing is the communication to the primary care physicians, to the family docs, and
right.
So
never heard
that
anything like it.
Yeah, no, I believe me, I could appreciate that, having once done professional relations for Blue Cross and Blue Shield. It was my role to interface with practices of all kinds, both primary care and specialty. And what you're describing is truly out-of-the-box thinking, where you would have a physician-led organization, Dr. Reed, do outreach to the selected, to the identified primary care practice in order to create a smooth onboarding process.
Right.
And
they
and
did
so
it
who's that?
for every one of the roughly 7,000 employees that were in the program.
Excellent. Do you happen to remember offhand how many primary care practices benefited from this particular program?
No idea. I never saw a number even remotely close to that because it was
Okay.
unnecessary for what we were doing.
Right.
We didn't
It
care.
wasn't an important. Yeah. It wasn't an important indicator of success. It was
Correct.
more. Well, and so that being the case, what was for you a powerful indicator of success for as long as the program ran? I mean, what aspects worked well?
At the time we were doing this, we had a company. Are you familiar with who MedStat is? MedStat
Absolutely.
was maintaining. Okay, MedStat was running all our data. And so it was very easy to track who was using primary care and who was not. Because if you had an employee who had a spouse who was also insured from another employer, they didn't have to pay attention to the rules to get full coverage for their medical care. They could do whatever they wanted. But they also did this. And we were able to watch that. So the metrics we were watching were discovering how many hypertensives we had claims for in the prior 2 years, and how many began showing up under the next 2 years. And we tracked clinical results, and the number of hypertensives being treated almost doubled. Because they went to their doctor, somebody took their blood pressure, and they go, "Oh, did you know that your blood pressure is completely off the charts?" "Well, no, I didn't know that." "Well, you ought to be taking this." And that was the fastest developing thing that caught me by surprise. I wasn't expecting it to happen that fast. But, on your first visit, what's the first thing they do? They weigh you and measure your height and take your blood pressure. It was so simple.
So you
One
looked
of the
at.
internal things.
So you were looking at clinical outcomes as a leading indicator of success for the
Yes.
program.
Yes. The goal, of course, was to keep our people healthy. It wasn't just a cost-cutting thing. It was trying to provide the best medical care we could for all this money we were spending. So that was a big goal in getting this whole thing done.
Excellent.
Now, a background, because you ask about motives, a background of what we were trying to do, we didn't publish. The goal was, we had determined through MedStat and a lot of other, eBri and some of the databases, that primary care was getting we figured about 6% of the medical care dollar. That was what was sticking to the hands of the people who worked in primary care. And our goal was to drive that 6% to 12%. Now that can happen in two ways. One of them is the primary care or the family docs practices would be doing more, so that would increase some income, but they would be doing less in an inpatient setting, and they were doing less with specialists. So the amount of money spent on hospitals and specialists, as that number dropped, the percentage of our dollar going to primary care would rise. We wanted that number to be around 12%. And we didn't run the program long enough before Meade was acquired by another company to get it up to 12%, but we were going in that direction. But that was the ultimate goal, because everything would go from that. But we never published that.
So Dan,
I
if
would-
you could you speak to
Go ahead, Larry.
some of the other outcomes that you saw? I recall in your presentations, you saw significant declines in things related to subspecialty care, the procedures that were done, hospitalizations, et cetera. Could you speak to that?
Well, I don't have the tables and so forth in front of me, but cardiac care was a big deal. And the number of hospitalizations we had dropped. And if you sorted out the easy cases, in other words, the cases that shouldn't have gone to a hospital to begin with, but somebody sent them there to find out something for observation or whatever. And so you would think that if you weed out all those 1 and 2 day stays, that you would have more complex cases going to the hospital and the stays would be longer. That did not happen. The stays in the hospital became shorter and they were less costly, other than the fact that they were shorter. There was less being done in the inpatient setting. And for some reason, there was also less being done in the outpatient setting. So the fact that the primary care guys were getting in it and staying with it means they were probably treating a lot more things that never got that far. That was our conclusion. As for individual items, that's just so long ago. Mental health was a real big deal, but we had a separate company that helped manage the mental health issues and those confinements, and that was our first step into this kind of management before we got to the medical side or the non-emotional side of the business. Does that help?
Yes.
Go ahead, Jed.
And so I was going to say, so pivoting a little bit, and really not to spend too much time on it, but what aspects of the program that you put together sort of fell short? You had mentioned prior some of the administrative challenges that you had despite the apparent simplicity of the strategy. Can you talk more about that?
Sure. One of the things, we had Dr. Reed's group. If it had gone according to Hoyle, the way the plan was set up to run is that Dr. Reed's group would pay all the claims. Now, first of all, there were no contracts with any physician specialist, or there were no discounts anywhere in the program, because the philosophy was, why do you want a discount on what you set it up so that you get a discount on unnecessary care? That just doesn't compute. So what we wanted to bring the cost down by utilization and by the intervention of the family doc. And so I lost my train of thought there for a minute.
Well, I mean, you were talking about structuring a program where essentially you were going to carve out primary care and allow...
Right. Not just primary care. We were going to have Dr. Reed's group pay all the claims, not just primary care.
Oh, okay.
Claims. We're going to pay all of them, because
okay.
he would already know if they were following the primary care pathway, which is the tagline we gave it. If you're following the primary care pathway, which means touching base initially with your family doctor, and any subsequent time that you had to change other physicians, you go back to your family physician. So that was the pathway. They would immediately know if you were following the pathway, and they would pay the claims. And it would have been very simple. What made it not work, the compromise we had to go through, was Provident, who was our claim payer on everything, would still pay the claims. The claim would go first to Dr. Reed's group. They would say, okay, yes, they did initially talk to their primary care doc, and they would send that information to Provident. Provident would then adjudicate the claim. That became clumsy. That was an extra step, an extra several days involved, even though you transmitted back and forth electronically. It was a cumbersome and unnecessary way to do it, except for the political issue that we didn't want to water down our relationship with Provident. We were getting a good price, they were doing a good job, but there was no clinical concept. We tried to go to Provident first to get them to administer it, and they said, there's no way we could administer this program. We are not structured to be able to do this, and we will not administer a primary care program like the Mead Health Alliance. He says, we can't do it. And we're not going to change our protocols for a single employer. And it makes sense. They had no experience in doing it anyway, and Dr. Reed's group had several other employers in the hundreds of employees where they were running the program smoothly. So even if Provident, who very wisely said they would not do it, which means we had to cobble something together that eventually led to the phasing out of the program just about the time I retired.
Yeah, understood.
So
but it was working. Yeah.
But it made it more complicated for the people to understand, especially ones who had coverage elsewhere, because they had contracts. They were following the traditional managed care, and our guy was told not to follow the traditional care, and some of the families got that kind of confused. They couldn't understand why we were doing it differently than anybody else, because they didn't have the clinical background to understand what we were doing. But
yes.
all in all, it worked amazingly well. But there was the fly in the ointment with the administration. And if I could have done without that, fine, but we might not have got it off the ground, so I agreed to the hybrid that was clumsy.
Yeah, and as I mentioned,
anybody else wants to try this, don't do that.
Well, and again, that goes to a couple of additional thoughts and questions, which is, if others were to take a stab at this now, present day, I guess that would be one of the recommendations or suggestions that you would make is maybe stand your ground, gain better administrative control.
But I don't know that. See, the problem that I wanted to mention here is who would then do the administration, because we had a clinician running the claim operation. We had a clinician that was running these things, and many of the people that worked with him were former clinicians. That this was not just a claim paying operation. You couldn't go to like a third party administrator to pay claims, although that's technically what they were. They had a different focus, and you're not going to find it anyplace else. Just like Provident turned it down, without the proper administration, this is not going to work.
Well, and Dan, that's an important.
That's not to say that you couldn't build one.
Right, and because that's an important point as folks think about this in the present day. There are, you'll be happy to hear, third-party claims administrators, TPAs, that are attempting to offer this kind of strategy and primary care focused strategy. And frankly, I think those third-party claims administrators would benefit greatly from a conversation with you, because you would be able to kind of share with them what some of the frustrations were that, frankly, I believe could be avoided given the technology that now exists, the AI that exists. Yes. And so, I mean, so, you know, if you were to do this all over again, what you would have done differently, at least what I'm hearing from you, is be a little bit more assertive around the role of Dr. Reed's organization as an example.
Right.
Right. And unfortunately, given the time period when Mead was acquired, if you would have been able to show up with that information around total cost of care, where you were achieving this higher primary care investment of 12% by reducing the total cost of care while at the same time enhancing compensation to primary care, I think that would prove to make a powerful argument in favor of what you innovated back in 1994, which again is.
I hate to say this, but probably not. And it only is because of the business we were in. You got to remember, we were in the paper making business. That is a hugely, hugely capital intensive business. Payroll was a minor issue, and that's not the case in a lot of companies. And if you split payroll down into benefits, and then you split it down even further till we were talking about healthcare, what I was saving the company, yes, it fell to the bottom line, but it was so small you could probably not even measure it. So it's not like it was 1/10 of a cent per share. It hardly registered. And yes, it was saving them money, but the goal was the clinical issues. Are we going to have a healthier workforce? And that's why that was the selling point. It wasn't the money.
Well, yes, you're absolutely right.
Employees enough. Now, this is a big deal. If you irritate the employees enough, that couldn't happen. That was not allowed to ever happen. That's why these people were paid so much money. In a capital-intensive business like this, you can afford very good programs. And that was the reason I could do all these kinds of things. I had the leeway to do it because we had the money to do it. And we did it. It worked beautifully. But we couldn't sustain it because of the administration. And it was just really, really frustrating.
Interesting. I mean, that...
So, if things have evolved enough...
Yes, but it's the other way around in most cases, where the cost of benefits is what is the driving element of the conversation. And it's really a return on value is what you're talking about.
Exactly.
With the focus on outcomes.
That's absolutely true.
So this is
Larry, Allie?
I want to jump in and ask a question because this is fascinating. Dan, your focus was on really a healthy workforce, and a healthy workforce is a happy workforce, is a happy employer. And if I'm wondering if that's undervalued by many companies, where they just take a certain amount of absenteeism for granted. They take a certain amount of people working with depression. They take a certain amount of people working with, diabetes or cardiovascular issues that impair their performance. I'm really wondering if in America now that is being undervalued, and there's maybe an inordinate focus on saving money to the bottom line. I'm just wondering, Dan, if you or you, Jed, might make a comment on that.
I have no clue. I've been retired long enough that I was very happy to hear you say there are TPAs who want to specialize in this, and if they could make that kind of thing run, we had another problem internally, because I would get questions all the time. How come we're not getting any discounts? And then I have to go and show them, look what we're doing without the discounts. And then it came, but if we had discounts on top of that, and they wanted to put the networks back in, and I said, well, no, it will be counterproductive. And it went back to we show all these clinical advantages of doing this, and they went away. But for somebody who's running a really, where payroll is a big percentage, I don't know if I could have carried that argument.
Well, you can, given the to help answer the question on the table, you can, given the power of the analytic tool, because there is an emerging community of benefit consultants who, Dan, are really beginning to understand that so-called PPO network discounts are nothing more than a shell game, where various participants in that whole transactional reality make up on tomatoes what they lose on potatoes. And what appears to be an absolute less than retail opportunity through PPO discounts, when you compare it to predictive modeling type of data analytics, you begin to realize, my goodness, I bought twice as much care as the covered individuals needed. And if a primary care physician, as you suggest, was an important part of the decision-making process, assuming they have enough data about the patient that they are caring for, enough information about the patient that they are caring for, they are more likely to ensure that the patient is receiving an amount of care, a volume of care that is consistent with their documented needs. And that sort of right sizing for care volume outperforms so-called PPO discounts in the minds of many. Now, not everyone for sure, but many who spend time looking at well-organized data around the documented needs of the covered individuals and the provision of care in the context of those documented needs. So it's a shame you retired, Dan, because I think you could be having a lot of fun right now with this kind of strategy on top of the administrative capabilities that have emerged over the past 3 to 4 years. And there are a couple of third-party claims administrators who don't even talk about PPO networks beyond the correct community of primary care physicians. They look at everything else downstream as something to be cannibalized by primary care and paid for on a pay-as-you-go basis as opposed to any sort of PPO network arrangement.
People would occasionally ask me, what, how much discount are you getting? And I tell them 100%. And they go, that doesn't compute. And I said, there's so much that we're not doing that discounts 100%.
Yeah.
When you don't use either the inpatient or the outpatient facilities, like the outpatient surgical program, and is treated otherwise, the discount's 100%.
That's a great way to put it.
Just another way to look at it.
Yep. Allie, I'm wondering if you have any questions.
I don't know if I missed this or not, but as far as the indicators for success, you mentioned financial goals of increasing that 6% of every dollar to 12%. I was wondering how you decided upon your indicators of success, and also were there also patient satisfaction metrics that you were using?
We did not use any patient satisfaction. We just didn't track it. We could sort of tell anecdotally, because the benefits administrators, of which there were some 80 out there, who gave us feedback constantly, that they liked the fact that there were no deductibles. There was none of this. There was none of that. They could go to their family doctors for virtually free, because we had a flexible benefit plan that had a deductibles that ranged from $150 to $1,000 a year. But the deductibles don't apply to primary care. I did mention that as part of plan design, but the deductibles. So you go to your family doctor for nothing. There wasn't even a copay. Some of the groups had a copay, some didn't, but that was a local issue. Primary care, for most people, their encounter with the medical community was their family doc, and they went for free. They loved that. So you had a high degree of satisfaction. It was the ones who had the more complex claims that we made the process more difficult than it needed to be. Oh yeah, but the liking the program was fine, especially somebody with $1,000 deductible, and there were a lot of people in those. You could go to your doc and pay nothing. So it had real pluses for patient satisfaction, because the majority of people touching the medical system was all through primary care, because we forced it. So it got good marks, and we didn't need to track it.
Yeah, that's important.
That was a good question. I hadn't even thought about that before.
Yeah.
Maybe that's something we could have tried. Thanks, Allie.
No problem. I think that they're tracking through primary care, if I'm not mistaken. Jed, I don't know if.
Well, it is. It's a growing effort to track patient satisfaction. It's an important part of the so-called triple aim, but it is patient satisfaction, frankly, is a leading indicator to what many of us look at as the holy grail, which is patient activation, where you have created a better healthcare consumer through this strategy, so that not only is the covered individual happier, but the covered individual is considerably more informed and insightful in terms of what their own needs are, and they're not likely or less likely to make a mistake as a consumer and ultimately cost the employer more money, because they are, again, in this trusting relationship with primary care that Dan and his colleague, Dr. Reed, foresaw quite a while ago, and tried to create. If your trusting relationship with your primary care physician is your source of truth, the chances are you're going to make much better decisions for yourself, and often be in a position to guide your own family that much more effectively.
Right.
So kudos to the Mead Health Alliance, a program well ahead of its time, but a program that resonates now in terms of the best way to approach this for self-funded employers who are genuinely interested in a high-quality, truly affordable benefit plan strategy for their covered individuals.
Yeah, there's another side issue that if you have discounts and you use an insurance company's network, well, part of that discount sticks to the insurance company's fingers. Everybody that plays a little bit goes to here and a little bit goes to there. And taking away those incentives, or I should say that taking away the networks is a financial loss to the people running the networks. Of course, that was all paid by the employer.
Yeah, no, absolutely. And very little transparency around PPO networks. And once again, as Larry described me, fiercely independent consultant, all things primary care, it's part of my penance for having spent 7 years helping to build networks on behalf of Blue Cross and Blue Shield. So I apologize.
Okay.
So I'm thinking this would be a good point to bring things to closure.
I do too.
Dan, thank you very much. I'm so happy that we reunited a short time ago, and it's wonderful to hear. I still remember coming into your presentation in the 90s when I was on the faculty at Wright State here in Dayton, and just thinking, God, this guy's brilliant. You and Bob Reed were.
I really wish we had run that. We weren't going to pay $100,000 to run it,
right?
Because we didn't care that much. It would have been nice to have the information, and I wish you guys had found the funding, because it would have been. It would have made it. If all my conclusions were played out, and we could document that, me would have never walked away from it, ever.
So I do have the documents that you sent to me, and thank you for not cleaning them out of your garage as you after you retired. Those are really valuable. When we write up the summary of this report, we will include the data from that, and I think you'll see that you as they say, you guys done good.
Yep, we did.
Cool.
And it was fun doing it. And Dr. Reed was one of the best people to work with I ever saw. He was really good.
Yep. Well, Dan Spiller, thank you very much for joining us. Jed Constance and Allie Abel, thank you very much.